Excellent. Well, it's an absolute pleasure to be here this afternoon to present on the virtual clinical pharmacy service. And I think this complements Mark's talk very nicely. Again, where the setting here is a public hospital network, and we're looking at an innovative approach to delivering pharmacy to our rural and remote hospitals. And I'll provide an overview of the services we provide, how we go about that, and some research findings. And so we'll start off talking about the problem here. So Western New South Wales Local Health District, we have a population nearing 300,000 people, and we service them through rural referral hospitals, district hospitals, multi-purpose facilities, and small walk-in health clinics. And these health services are staffed by over 7,000 staff. And prior to the pandemic, we're travelling around 13 million kilometres a year to provide healthcare. And like other health districts across Australia, we've got this large geographic area, a very sparsely distributed population, and an uneven distribution of the health workforce. And pharmacy was really no different. And most of our pharmacists located in the district were based at the 3 large rural and referral hospitals. And most of the clinical services provided to small rural and remote hospitals, or the services provided, really focused on medication supply and drug information inquiries and an annual audit. And due to the geography in our health district and the low patient numbers at each facility, it really wasn't feasible to have a pharmacist on site at each hospital. I know other health districts have looked to ways to manage this, and often they'll have area pharmacists or pharmacists employed across multiple facilities. But for us, even to travel between a few of our facilities, we're looking at over a week of travel. And historically, we've had a lot of trouble meeting the National Safety and Quality Health Service standards around medication safety. Now, we did run a trial of multiple telehealth services all the way back in 2016, and pharmacy was one of those. And so we took some learnings from that. So our vision really was to lead the provision of world-class virtual pharmacy services. And we're looking at innovative, accessible ways and sustainable ways of providing that to our rural and remote hospitals. And we're able to do this through a New South Wales Ministry of Health Translational Research grant. And these grants are designed to facilitate high-impact research that can translate into better patient outcomes, health service delivery, and population health and wellbeing, as well as building research capacity within New South Wales Health. Now, we started our project back, or our journey with this started back in 2019, prior to the COVID-19 pandemic, and before telehealth and virtual healthcare were as mainstream as they are today. And we sort of went live with our first service right when the pandemic just started in Australia in early 2020. So a little bit about what virtual pharmacy is. We provide the core clinical services that a hospital pharmacist will provide in a face-to-face setting in our larger base and district hospitals. And of course, the exception here at the moment is medication supply, which remains quite difficult to do remotely. And this is currently provided through the existing logistics network we have with our hospitals. So you can see there's a number of services that we provide. Some of the ones that perhaps were a little bit more than we expected were around safe and appropriate use of antimicrobials, which we call antimicrobial stewardship, and the multidisciplinary team rounding was something we didn't expect to be as important as it is, and certainly changed the way that we delivered healthcare at some of these hospitals. And I'll talk about that a little bit more as we progress. So when we commenced designing virtual pharmacy, there are only a few models of inpatient telepharmacy documented worldwide. And the model was designed around a high availability of video conferencing with an integrated electronic medical record. So in New South Wales, predominantly, we use the Cerner electronic medical record, which includes patient notes, pathology, imaging, and electronic medication management. So the virtual pharmacists work with the EMR, telehealth, and we worked with our telecommunications team to design the way that we would deliver virtual pharmacy. And through working collaboratively with health information teams, we were able to actually implement with a majority of existing systems, which really reduced our technology costs and also requirement for support. We actually have a decentralized pharmacy team, which most of our pharmacists are based at larger facilities within our health district. And we report through our existing governance networks. In terms of the technology we use, so on the pharmacist end, a laptop and a webcam with 2 screens, a mobile phone and a headset is predominantly what we need. We have been able to facilitate pharmacists working from home during the pandemic to help minimise exposure. We use network printing to print medicines information and medication lists to our facilities. We use the New South Wales Health solution for video conferencing called PEXIT. And we do have a physical backdrop that we designed for a more professional appearance as well, but it's not necessary for the delivery of healthcare, obviously. And on the patient end, we've got a wireless video conferencing cart referred to as a Wally, which is taken to the bedside. And there are a couple of pictures of the Wally throughout the presentation. And we use MS Teams within between the pharmacists to help communicate within our service. So the actual process of care itself, we have an assigned pharmacist to each of our 29 hospitals that we're providing virtual pharmacy to. And that was some feedback we had from the early trials that staff really wanted a designated person to deal with from day to day, and it really gives them the ability to meet and build rapport with all of the staff on the ground, but also some patients that might frequent the hospital. We had the opportunity to redesign the ways that we worked as part of the project, and we really looked for streamlined workflows and processes. And so part of this was using electronic referrals through the electronic medical record, and to provide a quality service to patients. Most, if not all, of our consultations occur via video conference. We leave comprehensive documentation in the health record for the local team, and a lot of our doctors are also the general practitioners in the town, so we'll often alert them that we've left a recommendation in the notes via mobile phone. And as I mentioned before, the multidisciplinary rounds and service rounding have been some of the critical components to ensuring high quality communication and integration of virtual pharmacy into our hospitals. So I've actually got a paper accepted with the American Journal of Health System Pharmacy, which describes the model of care. And you can go there to see some practical information and some design considerations we took when implementing virtual pharmacy. So I'll move on now to a bit around the research evaluation, as it was a research grant that the project was funded under initially. And so we had a number of aims and questions, and we really had a barrage of measures that we looked at to determine if virtual clinical pharmacy could improve patient safety and quality across our rural and remote hospitals across 2 health districts. The questions looked at medication safety, patient outcomes, perceived acceptability from patients and healthcare providers, and also some health economics. So the study design itself, we had a mixed methods study, and we used a step wedge randomized controlled trial, which is common in healthcare interventions. We have published the research protocols, so that's open access, so you can see all of the information in there, but we had a sequential and random crossover of clusters, which were 1 facility at a time, from both control to intervention, which allowed each of the hospitals to contribute data in both control and intervention periods. And so the data that we used, we worked with our health information teams and researchers to identify measures early and make sure we could collect these. And we collected predominantly the efficacy measures from the electronic health record, acceptability measures from a patient experience survey, and from clinical staff focus groups. And we looked at scalability by providing the service over a number of health districts. And we have a health economist that's helping us look at cost effectiveness. So these were the measures that we looked at, and apologies for the acronyms for people that aren't from the pharmacy world, but the measures really looked at capturing information from all perspectives. So we wanted to know from a patient, a clinician, and a health management perspective as well. And the addition of the qualitative components really helped to capture the human experience and perspectives of those involved in virtual pharmacy. So the research evaluation looked at over 1,300 patient admissions of greater than 24 hours. And looking at the patient demographics, we had a median age of 74. And we had roughly 500 patients when it worked out in control and intervention, and about 250 in the transition phase. So here's some process measures of the pharmacist activities. And you can see that we had over 2,000 occasions of service, and this was over a 9-month period. So what we saw was about a third of patients received at least one electronic referral for a review by a pharmacist. We saw more than half of patients on discharge to do medication reconciliation. Almost or over 3/4 of patients had their medications assessed in a medication management plan documented on admission. And over half of patients had at least one subsequent review while they were admitted in hospital. So in terms of what staff thought about the service, we approached staff at our 8 hospitals and asked them to participate in a short focus group with an independent researcher. And they were predominantly nurses and doctors. And we conducted these about 3 months after virtual pharmacy was implemented, to allow them to have a good experience. And these were some of the themes on the screen that were presented as benefits of the service. And some of these were around increased access to the specialist medication advice from a pharmacist, and an additional and trusted workforce and support. But I think sometimes the quotes tell a lot more. And we've published this as a research article as well. And so you can read the full findings there. So some of the things that we did see, though, were with this change in focus after sort of that 6-week mark of the service, where staff on the ground were more interested in being involved in the medication management, particularly nursing staff. And we did see improved communication within the healthcare team and collaboration with other disciplines as well. And that was both virtual and face-to-face. And predominantly that was through these multidisciplinary ward rounds, where for the first time, we're really placing patients at the centre of their care. And you can see that from the second quote on the screen there, from a nurse at a rural hospital saying, you know, for 24 years working at our hospital, this is the first time we've had a proper multidisciplinary round. There were some other great quotes from our small hospitals, and one of them was from a doctor who said, I thought maybe this would be a bit intrusive, and well, it didn't take long to see it would be a great help. Well, it was both educational and shall we use the word collegiate. There were a few suggestions for improvement, which included a simpler process for contacting us, which we've implemented, and looking at it further expanding the service. From a patient perspective, the patient-reported experience measure, we had a 12-question questionnaire. We had about 190 surveys returned, and you can see that the patient acceptability in the model was very high, with close to 90% for good or very good on a 5-point Likert scale. And I was video conferencing with a patient this week, and as we were sort of completing the consultation, she sort of turned to the nurse and sort of said to both of us at the same time, "Oh, isn't this good? This is so great. You know, I can have a chat to a pharmacist, you know, in my small town." So sometimes we're seeing that, you know, just anecdotally day to day as well. In terms of the national standards, well, we looked at best possible medication history, admission reconciliation, discharge reconciliation, and patient lists. And we saw a 33 times increase in the odds of completion of a best possible medicine history, 11-fold increase in admission reconciliation, and a 4-fold in discharge reconciliation. The med list jumped from like 1% to 32%. So we had a massive increase there. We didn't see an increase in the completion of VTE assessments, which was something else we were looking at. Not clinically or not statistically significant, but we did see an increase from 21% to 45%. But we did have some other projects assessing VTE at the same time. In terms of patient outcomes, the study numbers were too small to really detect a statistically significant difference in those. But when we looked at potential medication-related harm, we did see that the pharmacists were identifying a large number of interventions. And what's comforting here is sort of 73% of the recommendations that pharmacists were bringing to prescribers were actioned. And these range from relatively minor all the way through to quite potential or potentially dangerous medication errors. As I mentioned earlier, we didn't expect antimicrobial stewardship to interventions to be quite as high, and most of the recommendations were around omitted medications from patients' medication history, and also recommendations for dosage adjustment based on laboratory results. So some benefits. Well, we've now got a new dedicated workforce and a new specialty for pharmacy in our health district, which offers some more career progression for our pharmacists. We also have now this service. We go live at our last hospital next week. So we've really increased the equitable access to hospital pharmacy services right across our health district. And on the right-hand side in this table here, you can see some of the NSQHS standards around medication safety, and all of these ones here, the clinical pharmacist can contribute to. We've also seen some more engagement with our community pharmacy colleagues, and we're currently collecting some feedback from them at the moment, which we're hoping to publish later in the year. But a couple of the themes out of that were increased efficiency and having a central contact point and increased patient safety on discharge from hospital. We provided a lot of education as part of the service. We had over 170 staff attend education sessions, and we'll be continuing those into the future. And as I mentioned earlier, we've had more engagement in medication management and safety. And as part of the research project, we've developed relationships with academics and health researchers. So what does the future of virtual pharmacy look like? Well, currently for us, we're at the end of a 2-year process. And so we're still really focusing on the here and now, and we have still developing some plans for the future. But what we've done is taken a smaller research project where we're providing a service to 8 hospitals. We're now providing, or we will have next week, be providing to 29 hospitals, and that's over 100 patients as of today that are currently being seen by a pharmacist that wouldn't have before. We're on the same health net or the electronic medical record in 4 health districts. So there is a chance that we could potentially look at scaling the service further to more health districts. We have also trialled virtual pharmacy in a metropolitan context, where we had a 3-month trial to an elective orthopaedic ward at Royal Prince Alfred Hospital in Sydney, which means that or demonstrates that the virtual pharmacy model is rapidly scalable and transferable into other health contexts as well. So virtual pharmacy, as I mentioned, we're still integrating into our existing pharmacy stream, and we're working within pharmacy on other quality improvements. We're providing locum relief to our sole pharmacists at our smaller hospitals. We're also looking at rotational positions through our base hospitals, and also supervision of students and intern pharmacists. I believe going forward, we'll probably look at a hybrid service offering where there'll be some face-to-face component of our service. In terms of expanding our service or looking for new models of care, there's a great need in residential aged care, as you've heard in the previous talk. But there might be other models of care that this could be adapted to in the future, such as transitions of care, virtual discharge, post-discharge follow-up, hospital in the home, or other in-home monitoring programs. So just broadening the scope a bit further, I think it's unlikely that the technology we're using today will look anything similar even in a few years' time. We'd love to have a video conferencing machine that we could remote pilot around the facilities, but we're trialling some smaller form factor, or we will be shortly. But I think what underpins a lot of this, which you've heard from a lot of the presenters today, is the better availability of health information. You know, single digital health records, less fragmentation of health records, and interoperability between systems will really expand the scope and allow us to deliver services more broadly across the community and integrate well into healthcare more generally. I might leave us with a couple of lessons from our telepharmacy journey, and that's that we're heavily reliant on our on-site colleagues, our doctors and nurses and admin staff, and so spending time with them up front to explain the service and to build in structures for support and communication and continual service improvement is really important at the beginning. By working with subject matter experts in data and technology, health clinicians and researchers, that will really help ensure you've got a fit for purpose clinical offering and technology solution. Simple processes and technology is important for usability, and having your executive on board with your project is really important in the early phase, and we've been able to see the translation of this research into a business as usual model and a significant expansion across a health district. And I'm open there for some questions.
Thank you so much, Brett. What an incredible story of scale. And what I love so much is that this was really driven by the national standards, and you've really been able to address, you know, that core framework in your quality, you know, in your governance structure. I guess the question for me is, was it easier to get, you know, traction and support for this project because it was a need from the national standards? Do you think that was part of it, or are there other levers?
I think it was multifactorial, but I think definitely one of the key drivers from a health executive point of view, a health management point of view, was being able to meet those accreditation standards. But really, pharmacy has been a really easy sell because medications are complex. Our patients, our doctors, our nurses all know that, and they really value the support in this space given it's so specialised. And so, you know, we had really heavy grassroots support from all of our clinicians that, you know, were really quite adamant that this program had to be expanded across the district.